All right, so thanks everybody for your patience, and we didn't count on some of the complexities of the itinerary today, so I apologize. It's my pleasure to introduce Dr. David Eidelberg. So David is a neurologist. He's the Susan and Leonard Feinstein Professor of Neuroscience and the Director of the Center for Neurosciences at the Feinstein Institute for Neuroscience, located at Long Island Jewish Hospital. He has his BA from Columbia, went to medical school at Harvard, did his neurology residency in the Longwood program, and has been a leader in the analysis of the sort of metabolic topography of Parkinson's disease and other degenerative disorders. Also worked in dystonia, is more interested recently in Alzheimer's disease too. PET imaging, metabolic PET imaging in particular, has been a key technology that he's used, and I'll talk about the advantages of the approach. He's got an impressive CV, very fantastically productive, more than 220 papers. We were talking this morning about a paper he's got in press in current issue of PNAS, right? So we had press after him this morning. Very energetic and interdisciplinary guy, and it's my pleasure to introduce David Eidelberg to talk about metabolic brain networks and neurodegenerative disorders. Thank you, David.
Thank you. I can't see it. Interesting. Perfect. Thanks. All right. So yeah, this is almost a story about. One of the people who interviewed me or spoke with me earlier. We were having such a good time in the cafeteria that we didn't realize that it was time to come back and give this lecture. So, apologies for my tardiness, but we'll try to catch up. So Tom Grabowski, very generously spoke about these different things, and in a way, looking back, I mean, it was sort of not exactly. We didn't set out to develop a technique. It was sort of, it found us. It was probably something that was always out there. And we were fortunate in that the types of imaging data that were available for us to look at turned out to be so very well suited to be analyzed in this, at that time, rather new method of network analysis. But in the back of everything was the concept of, maybe these diseases are diseases of systems, of whole brain circuits, and it's not just a single region. And a lot of our neurological tradition has to do with localization and single regions. And in a way, it's not that big a jump to go from that concept to using the whole network as the guide to the disease. But you'd be surprised at the level of resistance in the community to going beyond the single region, which to me was kind of like reminiscent of phrenology or something. It's so close, that region is conferred with these attributes, when we all know today that it's not any one region, it's the whole network. And are there ways to not say, I will approximate the whole network? Rather, I'm just going to get something that's a bit like the network using simple computational tools and see how far it will get us. So the fact that we're still talking about it over 20 years later means that there had to be some validity to it. And what is this network conceptualization? This came from one of the postdocs, a German guy in the lab, who said you have to have a cartoon, and which is to me very molecular. You go to any molecular talk, there's a cartoon, and we in brain imaging, we have images. We don't need cartoons, but in fact we do, because sometimes these things reach levels of complexity that go beyond what one can be expected to believe. But the cartoon sort of gives you a guide to the concept. And it goes as follows, that if you were to have two different groups, one would be a normal group, and by normal I mean one fully matched in every possible way to a group of people with disease, age, gender, level of education, having had Wheaties that morning or something, just the various secular effects. Except one group had a disease or a genotype, actually, so even more interesting variation of this concept. But just the disease proper, if you were to combine them into a single group, a pot, and throw it all in, and you would hearken to a sort of logic that says, well, variability in this pot could be parcellated mathematically into variabilities to do with disease, which ought to dominate because that's the major source. If one were looking down at these two groups of individuals, there's nothing to distinguish them actually. Here there is in this cartoon, but when done properly, the outside observer wouldn't know that half of that sample, let's say, had a gene for Huntington disease or carried a gene for dystonia. In this case, we're talking about a disease with people who have involvement clinically. But what do they tell you in medical schools? Do a t-test. I can still hear it after so many years. Do a t-test. Compare them. That's only one way of looking at it. That involves, are the means different? Maybe the means are a little bit different, but what counts is the variation of the entire sample, and if that could be captured through some logic. That logic is in the four principal components analysis in that general category of decompositions according to covariance pattern. And if we're good at what we do, we should be able to extract completely pure Parkinson's disease related networks that ought to be diagnostic biomarkers going forward into different groups of people. Of course, nothing is perfect, but it was worth a shot at least. So this is what the product of that effort looked like. This wasn't the initial try, and we were just in that prolonged coffee break that explains my lateness here, was about what the graphical formulations of these networks look like and how they've evolved. We use the MR as a sort of a coordinating template for this, but you basically have, this is according to metabolism being either relatively increased over baseline levels or decreased, red being increased metabolically and blue being decreased. And it's just a fascinating personal story of an immense form of opposition that came to the even intimating in the most simple way that the red areas were real. Wouldn't you know, these are diseases of low global metabolic activity, aren't they? Alzheimer's, Parkinson's are all the same. Your brain activity goes down. And if you're going to be doing any form of normalization, those red things are pseudo. They have to be wrong. And it turns out Parkinson's disease, your global metabolic activity is normal. So that argument is Alzheimer's are yet to be, there are red areas that are probably biologically correct too. They are indicating abnormal connectivity. But for the red areas in Huntington's and Parkinson's are not to do with lower global. And in some degree, as I'll show at the end of all this, those are the targets of intervention, both neurosurgically as well as by drug treatment. The red areas, I think most people who like neurosurgery for Parkinson's would say, aha, posterior putamen pallidum, we did pallidotomies. You have ventral thalamus, here. And, that those are areas known from the time of Cooper and Narabayashi as being tremor sensitive to tremor as well as akinetic rigidity. And then there's even been experimental studies to do with dentate nucleus activity. And these areas, in the times that they've been recorded in vivo, are overly active. And would they be benefited by being cooled down by cryotome, by DBS, or by levodopa? And in fact, that's what we'll be talking about. The other hand, the blue areas, these are not blue necessarily by dint of loss of cells, because in the blue areas are there in prodromal people who just have REM behavior disturbance that actually is not unique to being demented or MCI status and Parkinson's disease. Healthy cortex and a postmortem found to be healthy. Why is it blue? Is it's deafferented, so monoaminergic ascending fibers, but also just synaptic relays through the thalamus may be reduced. These red areas are just incoming inhibitory synaptic activity coming in pallido-thalamically. The FDG is about synaptic activity, be it excitatory or inhibitory. What happens in the next synapse is about whether the original one had been inhibitory, GABAergic, it would be decreased. If it goes up, it would have been glutamatergic. So one could deduce. And the autoradiographers, a lost art, but people like Crossman and Brochi, when he was younger, spent many years trying to track back what these relationships were, and they were found to be robust. The cortex was deafferented by these mechanisms, so the blueness is rectifiable. It's not loss of neurons, it's hypoactivity to do with deafferentation. The take-home message is that it's one unity, one ensemble of covariant networks under one network and not individual players. So that the next step is to quantify the network, not to try to extract individual regions. Now, one of the definitions of network in the field is to have that the network's properties are have less noise than the individual components. And that turns out to be proven, not just in Parkinson's, but in all of these kind of covariance patterns. So the red areas of Parkinson's, well, we did postmortem in a number of these people came to autopsy ultimately. And so we just want to be certain that blue was normal tissue in the cortex, which it was. But so was red. Red, there was no cell loss. It's just in vivo functional increases. The cell loss is in the substantia nigra, where there are Lewy bodies. There's no other discernible gross histopathological. Is gross the word routine? Tom, I don't, H&E. There's no issue. Now, the other thing is that this type of technology will do, and these are all learning a language for a few minutes here, because I want to be talking about things that are not in the normal lexicon of words that we use. So expression is a measure of how much a network appears within a given brain. And it can be measured in a derivation set, so it can be measured in people whose brains are being used to derive a network. But more importantly, as neurologists, is to measure it prospectively in individuals and new populations for validation, but also that is going to be our basis of gauging disease progression by network activity and by drug effects, by modulation of network activity. So the y-axis reflects the subject scores, how much the network is expressed, and here are normals. Notice how tight. I mean, they're interchangeable, and they are z-scored at this point, so that it's a mean of 0, and the standard deviation is a unity. And this derivation set of 33 Parkinson patients had a difference in the means. And by the way, this is kind of honest. I didn't just paint these over and make them black so that, look at that, no overlap, G medical, the DAT scan, not one case is different. They're all properly assigned because dopamine is about, the loss of dopamine is sensitivity. It is different than normal. These cases all have dopamine loss, but it picks up some other features. So we're going to get into this in a second, but notice you do have some normals who are age-matched, but they're at the high end of age that have an overlap. I would tell you that at this point one doesn't know from this one network if these are prodromal for Parkinson's. But when you look at multiple networks together, one can get a pretty good sense of whether it's normal or an incipient disease. So in order to have a discussion, so I talk about this kind of musing, it took 5 years to go from the last statement to the current one in order to figure out how will you do the measurement prospectively in a standardized fashion on individual cases. And to understand that involved some knowledge of linear algebra in order to make that happen. But here you have a collection of another 33 prospectively scanned normals and Parkinsonians from our own institution in this case. And you see a pretty similar looking arrangement. Notice how nicely the normals are behaving. I like to see normals because I want to make sure the zero is where I say it is. So critical, because if you have meandering baseline or failure of test-retest validation, then you're not in the game. You have to go home and start all over again. At least I'm taking my marbles and I'm going to play with you unless you satisfy those requirements. You can only imagine how much fun that is. So here we have the data set and here's the derivation. Now, so those autopsies had to do with their own institution and some who were referred by Stan Fon from Columbia. Now, in order to make this thing work and be valuable, so of course it works, that's definitional. It works for me, not for you, but it works somewhere. But for it to be used as a metric to gauge Parkinson's disease, it can't just be working in Manhasset, New York, or in Philadelphia, or in Palo Alto. You have to have things that are going to work anywhere in the world. So here come in our Chinese colleagues. These people are from Shanghai. Same American network is projected into these Chinese data with satisfying results, just as an example. That's just to give you a flavor how it's the same American network. These guys have actually derived a pattern that is rather similar to our own, that they think is the PD. I don't care which one it is, but we are going to have to use only one day for trials. That can only be, it's like Greenwich Mean Time. You can't have Beijing Mean Time, it has to be one. Now, there are other mimickers, as neurologists, those of us who've toiled in those vineyards know that not everything that is Parkinson's-ism is Parkinson's disease, actually. In fact, it's probably 2/3 of all comers to a movement disorder clinic, even with some history of symptoms, 2/3 have idiopathic Parkinson's disease, as exemplified by nigrostriatal, deafferentation, and midbrain Lewy bodies, and other Brock-like features that can be found. But there are 20 to 30% of people have something else with Parkinsonism that may not be easily discerned. MSA is the most typical look-alike syndrome, and there are really different flavors of MSA. It's one disease, and if you look at that network, this was an original network we wrote about in 2008. Tom Eckert of the cartoon fame is the person who had published some nice papers on the MSA and PSP networks, and Kathleen Poston, when she was with us, validated the MSA network, and now in 2 other populations. But the pathology is different. It's postsynaptic, and therefore the administration of levodopa is not as diagnostic. It will not be diagnostic. The non-response to levodopa may be viewed as diagnostic. However, how many MSA patients initially do have responsiveness to levodopa? Curious. Very many do respond to levodopa initially because the nigrostriatal piece of the network may go first, and then the postsynaptic piece in the striatum follows. And but back at the Mass General, C. Miller Fisher writes it down in his book as a case of Parkinson's disease. 25 years later, it comes time to randomize to a clinical trial. So here's a case of Parkinson's disease. And so it happened. And we scanned the person. They were a bona fide MSA case all along. Dr. Fisher saw the levodopa response, and he diagnosed it as PD. But then they never followed the patient more often than every 10 years or so. So who knew? But anyway, the bottom line is whether you're MSA Parkinson, MSAP, or MSAC, MSA cerebellum type, same network as it happens. And I won't, those interested, I can tell you afterward, but there are extensive data sets from Korea, from Chong Lee, where he has large numbers of both, and that they're identified by the very same network. So different phenotype, but same underlying disease. Prospective proof of it with postmortem by Kathleen Poston. And and a Chinese replication. I picked the Chinese one just because it's nice, but there are different groups in the world, and I'll show you with CBD in a second. There are different, this has become a sport that's open season everywhere for people to scan their subjects and look, either to use our networks in an attempt to disprove them or to derive their own networks to prove that they're better yet than the original ones. So I challenge, that's an open challenge to people to supersede. And the reason our networks are so good, I think, is just the time we took and the homogeneity. There were real checks, but it's not that our networks are truly better than anyone else's. Just it's useful to create standards for replication. And remember, at the very end of this, we're going to learn that there are errors that are made by misclassification that can be deaf to new therapies for disorders at the early stage phase 2 level. So this is not just academic, competition. This is to try to get it right and help clinicians who really might otherwise rely on flying without instruments to try to get these classifications correct. PSP is another one. I won't belabor that similar situation. PSP is more common, it seems, and that there are some nice replication sets for PSP from Holland and from Germany. More to the point is, can these networks, so they have their own lurid prurient interest in us, but can they be used diagnostically in such a way as a computer-based mechanism of classification? My agreement with Lancet was never to call this diagnosis, right? Because the letters came in, and I think my fingers are still singed from seeing those, at least metaphorically. People were concerned that I'm trying to destroy their careers as neurologists by having a machine do their work for them. And certainly that we need people a human being must make the diagnosis, and this is entirely supportive. Now, this is just what our original data set looked like in a study we did with Stan Fahn in New York. 170 odd cases over 5 years, and they were cases, the only distinguishing feature was that the clinicians, which I was not one in this case deliberately, were not able, it had to be that me or other imaging people were not there to contaminate the natural history of diagnosis, which is kind of an important thing we're going to look at now. Natural history was that they came to the office after having been seen by general neurologists, and the general neurologist said, I don't know what you have some kind of Parkinsonism. You better go to Stan Fahn, who then said, I don't know what you have either. Let's follow you, but we'll get you a PET scan as part of this protocol, and we'll see. And I'm not going to look at the scan. I'll never know what it shows, but this will be helpful in the future. So this is what the data looked like in terms of 3 networks. And at that point, we had not had a CBD, corticobasal degeneration pattern yet. But at least MSA and PSP added to PD occupy around 95% of all idiopathic. All cases coming that are not of vascular origin, so MRI negative cases coming to the clinician. Would you agree with that? So between 90 and 95%. This methodology allowed us, though, to attach. We said, okay, we're going to use the three networks in a technique called logistic regression analysis to classify people based on these certain coordinates in terms of their scans, and how much their subject scores for these three networks would help us make assignments based on optimization of specificity, mainly, as people with definite Parkinson's disease or definite atypical. So the first level was Parkinson's or not. But we allowed for an intermediate situation of I don't know, so indeterminate. And that is so important because people who were not diagnosticians who refused to honor indeterminate pay a price later of 50% incorrect diagnosis. And these are the net statistics. The thing that was intriguing to us is under 2 years of symptoms, this was still pretty good. A sizable number of patients in this group were early stage, and yet it really produced decent specificity. So this is a diagnostic test, not a screening test. So don't worry too much about sensitivity. It's something we can, I think that's where the dopamine imaging is better. It has almost no use as specificity. Positive predictive value is what counts because am I right or wrong in my pronouncement? And it's those wrongs that are, if we can minimize those errors, that would be a nice thing. So I told the story this morning. People, I get a call shortly after the first thing appeared from India, and they said, our government does not want to pay for DBS in people who don't have Parkinson's disease. And that we have a lot of patients, because it's India, it's a big country, a lot of people. But we also have a lot of pressure on the DBS surgery, and yet we read that a good number don't have Parkinson's disease anyway. Do you have a way to separate this out? So they're not asking me this. This is actually told to me by one of their nuclear medicine physicians, a gifted woman named Dr. Tripathi, who she received $3 million from the Indian government to conduct this study in New Delhi with two clinicians. And she just said, well, will you help us analyze it? Sure, whatever. And then 2 years later, there she is with her data. And this is what it looked like. So for people who like informatics, this is a different kind of distribution than the American one. Just if you can, you actually don't have as much variability in the PD group, and you have a little bit more, just these are kind of subtleties of these distributions. But here's the thing, we used our American networks and our American cut points derived from the first study blindly into the India data to classify their cases. And this is what it looked like. Notice many of them were under 2 years of symptoms, which was her goal to begin with. And there is a remarkably good positive predictive value and specificity in the India data. And the sample size is comparable, little less, 134 people, but this is still, this is without rederiving any new fits. This is an American-derived formula for logistical regression based on our data applied to data from India with no new rederivation of networks or anything. So this is kind of remarkable. Why is the positive predictive value better in India using the same parameter? It should be worse. Typically, the overfitting errors are on the part of derivation. So whenever you go forward, it's degraded. How come this is even, it's probably not statistically significant, but why is it so good? And it bothered me enough to find out. And it's that they don't have residents and fellows. So there's no variability in the outcomes. So the problem is all case ascertainment. We have much more variation. And it looked at the end, post-mortem rates are almost nil in India, so we would never know. But there was all the errors occurred. There was among those who were misclassified, a good number were misclassified not just based on the clinician, but the clinician himself had been wrong in New York, that is, as proven by the post-mortem. So we're always using the clinical diagnosis as the gold standard. And that may not always be correct, too. The other thing is, who cares, right? I mean, this is, so they have a morbid disease and whatever. Well, in the end, we don't have cures for any of these things. What does matter, though, is the length of time for a clinician to reach his or her endpoint, according to Andrew, to Lees and Fernley, and Andrew, and what is it, Andy Lees, and what Gibson Lees, these famous papers, that a good expert, so when you go into their data, 2/3, even at Queen's Square, were wrong initially. But after 2 years, it was getting very close to convergent, to concordant, if you will, with the postmortem. 2 years, and by 3 to 4 years, it was 99, whatever they reported in that paper. It's kind of interesting. So it took that length of time to be certain. They didn't know when they sent these people for PET, and we looked in all these cases as these papers were being written. Well, how many years did it take from the initial contact with the patient, the first diagnosis, to the endpoint? How many cases were they revised diagnoses, and so on? And it turned out that here the imaging got you to the endpoint correctly 3.5 years on average before the clinician did. So why that matters is for clinical trial selection, but also for treatment and overall prognostic features. So it becomes a non-trivial matter. Finally, in Korea, which is the opposite, late stage patients followed by one clinician, superb clinician, Chong Lee, trained in Vancouver. And Chong Lee's a very competent person, but he has no assistant. So I guess there's no variation actually in the endpoints in Korea. On the other hand, if we use his own endpoints, we get superb concordance. These are late stage cases. In fact, they're more like what DBS referrals would look like in this country. CBD, just to tell you, that's the lung disease. Martin Needhammer in our group, a great guy, has done work on this. And here we had, here's the original pattern. So this is derivation. This was in Brain a few months ago. In Holland, they had a lot of interest in CBD and Groningen. And so they used our pattern. In fact, they had their own pattern that we confirmed in both directions. Very nice. And then in Freiburg, Germany, they don't have controls. It's just a clinic. They don't care about controls. Why bother? We know what normal is, right? But it turned out that look at their distribution of CBD values was on the mark, and they had postmortem confirmation. So the thing that bothers many people in Europe, maybe more than it should, what am I missing? It doesn't bother me terribly. CBD versus PSP is quite topical now in the differential diagnostic. I don't know if it's more in the psychiatric world, the CBS, but these are, in the end, forms of tauopathy that have different sort of topographic distributions. And this form of analysis is helpful in that regard. You can really separate them quite well, as you can see the ROC. And this is all prospective, so these cases are not the derivation group. I mentioned earlier that we were quite interested, just to tell you, in Alzheimer, FTD. These are kind of not neurobiologically that fascinating, but it does truly turn out that these patterns are they really do separate all tauopathies from all synucleinopathies, and it has value, I think, in a broader sense. So let's shift gears for a second and see about these patterns. Do they tell us anything about the tempo of disease progression? Is there going to be a way of measuring the rate of degeneration in the brain functionally? And if I were to know that, how early can I die? Is there a prodromal preclinical period? Can I determine? And moreover, is there some kind of progression over time, a rate that is finite that I can modify through a disease modification? What do they call neuroprotective, if you will, strategy? That's a disease modifying. So far, none exists, but could one at least have a metric? And let's discuss that for a few minutes, and then finally I'll tell you a bit about what the placebo effect looks like. And I'll hurry through. So part of our Udall Center, we work with John Trojanowski's group at Penn. It was Andrew Sidoroff originally, to study people with RBD, REM behavioral disturbance, for people you may have heard a lot of, kind of a popular disease among neurologists. Is it a disease? It's a phenotype that half of the time will phenoconvert over the ensuing 5-year period into some synucleinopathy. Generally speaking, it's idiopathic PD. A small percent develop MSA. But they don't get the tauopathy look-alike piece. So and this was beautiful work from the Mayo, where the PSP, Alzheimer's, these things don't happen to these people. It's exclusively a matter of synuclein deposition. So we figured, is the PDRP network, is this network somehow registering in phenoconverters to be for the disorder? So these are all our local RBD. And by way of background, this is the preclinical hemisphere of a person with idiopathic Parkinson's disease. So these are individuals with hemi-PD. That's one of the interesting things about Parkinson's. It's the only one of these neurodegenerative syndromes that actually has a phenotypic prodrome. Half of your body doesn't have it, to begin in many cases. And we studied that in a series of papers, the rate of spread of the disease to the other side. And a remarkable thing is that the network expression is equal on the two sides of the brain, even though one side of the brain only has symptoms. So it's a neurodegenerative process. There are other features like dopamine loss below a certain threshold that is going to promote symptom. But it isn't, PDRP is not a proxy for symptoms or for levodopa exposure, mind you. It's just, it's a proxy for disease process. So here you look at the ipsilateral hemisphere, and this shading means preclinical. These are clinically normal. And then these people already phenoconverted and just progressed over time. And in our exploratory RBD cohort, now entering year 4, no phenoconversions so far. And we're going to be looking at, they've been followed longitudinally in our cohort. So the nice thing to see is that the RBD level is abnormal, and it's on track with the MIPD. Now, so I was not satisfied. That's so what? I mean, yes, there is an intermediate level PDRP in clinically normal people. They have RBD, is this going to be predictive? What's the point of all this? As Dr. Plum once told me, this is such an expensive and difficult technology. Why would you do it if you're not going to be helping somebody or learning something in particular? And I always have his voice in my mind castigating me. Like, come on, why are we bothering? And in fact, that was justified, that comment. So I wanted to see if this network measurement is adding information to a person who clinically comes to a sleep clinic as RBD. Do you all know what RBD, how it presents? Interesting. It's these vivid dreams. You have a failure to basically maintain the apnea of your limbs. You normally go limp like a cat does, and being dragged. It's sort of a way that the brain will inhibit you from acting out your own dreams so that you don't beat up your spouse or bed partner or whatever. And so, wouldn't you know, it's the spouses that bring these people, and my husband has these vivid dreams and he kicks me, and they're bad enough, I'm convinced from having seen these patients. It's not a trivial matter. And half of them phenoconvert. So I had this idea. I was reviewing someone's article for a journal. I said, these people have scanned individuals with RBD and followed them. So they actually know who's going to phenoconvert. But I couldn't approach them naturally in the peer review process of their own article. So I was certain to reject their work first, so they'd be they'd be desperate to work with me. No. Of course they were. These are, I'm kidding, but I mean, I wouldn't do that. These are people who were very well known and highly achieved investigators in sleep physiology in Montreal. And after their paper had been accepted, I approached them and said, would you allow us to work on these scans? Because independently, their scans were SPECT images of cerebral perfusion. And independently, we'd found that without dopamine on board, those are coupled rather tightly. It's only as people receive levodopa that you get some rather interesting phenomena of uncoupling and blood-brain barrier aberrations. So, wouldn't you know, you thought I was kidding. The following, he was not kidding. The leader of this group said, I'll only do it if you make me first author. And I said, but you don't even know what I'm going to propose. We haven't done anything. If you get a result, this is in a French accent, because this was from Quebec. And he said, I insist on it, otherwise you can't publish the work. I said, look, there's a kid who's going to do all the analysis. I'll give you the senior authorship. And even if there's no result, you can have the senior authorship, but you'll have to write the paper in that case. And he made me put this in writing. So the first thing I was kidding about, this is not a joke, and I was desperate enough that he had his paper accepted, so I was now the desperate one, right? Tables are turned. Anyway, I agreed naturally, and the results are amazingly interesting. Firstly, on average, even though it's a scanning of a primitive sort, I'll say that, because to get back at him, but it was primitive and it was blood flow, but it worked. You could quantify. So in fact, there have been some other work moving between modalities. The derivation ought to be with the most stable technology one can find. The testing can actually sometimes be in other modalities that are less demanding from a signal to noise standpoint. So this is the group in Quebec. And this is only to show you that with passage of time, you shouldn't tarry. The Chinese caught up. We'd already, by the way, our results had been published, but then they published this in Brain after ours had been in Neurology, and using their own PDRP to sort of validate everything ex post facto. But so this has been proven. What did count was the prospective utility of the procedure. And that's why I'm kind of kidding around, but to bring this home, we knew who had phenoconverted, although those identifiers, no one in my group was allowed by our rules to know who was a phenoconverter. So we did all the measurements, sealed them, and put them into third-party hands, and then they gave us opened the blind, as it were. Very important to maintain these things. And you could see the people who phenoconverted, there were, of a total of 17, these became either PD or DLB. They were really kind of PDD, if you will, so they were kind of rapidly evolving PD with cognitive disturbance. A number actually phenoconverted to MSA, and then the remainder did not phenoconvert. So the shocking thing is that all the phenoconverters, at least the majority of the ones phenoconverts to PD, were above 1. They had an abnormal, by 1 being the sort of lower, that's 1 standard deviation of the normal mean. And of course, you have several phenoconverters to B here that had yet to phenoconvert. But what was quite interesting is age is a very important predictor of phenoconversion that was independent. So if you factor, as I'll show you in a sec, both together, they're appropriately classified. They're just too young to have phenoconverted. You needed a little bit of time, and 2 of them had phenoconverted. The other individuals here became MSA, and they had negative PDRPs, which is a feature of early MSA we could discuss. It's an inverse of PD. They have MSA-RP too, but they are characterized. We found that a number of patients have negative, by deeply negative, Z-scores of negative 1.8 or lower, and they are MSA. They're not normal. They're on the other side of normal. So if you include age as a covariate, they're nicely separated. And, when will it stop? My meddling is that I was actually interested in predicting from this when they would enter the phenoconversion zone. And since you know the rate of progression linearly, you could estimate. So we're studying that. We don't know yet exactly. In terms of our pen data, which ones will actually phenoconvert more sooner or later. Because that's what we want to deliver to the patient. We want to say, I'm sorry to tell you, you are at risk, but it's likely based on your age and your network is it may not be for a very long time. So that's sort of what interests us. So I'm going to close with just one. I have 5 more minutes? Or 5. The PDRP's relationship to UPDRS is such that they're not interchangeable metrics, right? Because if they were, here's Dr. Plum again, they're the same thing. Pay a nurse to do the UPDRS. Why are you doing this? So I hear that at night too. Does that mean Haldol, or should I probably come? The TV, my dog tells me, When you have this type of study, notice how the UPDRS and the PDRP are tracking in parallel. Now, in a clinical trial environment, what happens is there's blinding, and you actually have scenarios where people, this is from a viral vector, double-blind, surgically controlled study, sham surgery versus subthalamic nucleus, AAV-GAD. The notion is to take this is my caplet, and the idea is to make a excitatory glutamatergic projection into a quasi, GABergic one through the introduction of GAD. So, but these are people who just had sham surgery under the blind. And so the PDRP itself, measured in them under the blind, is collinear with the early stage rate of progression, meaning a linear process. And you can show this through more sophisticated means. Each one of these bars is for 23 patients, parenthetically. A lot of data. But look at the disparity, the placebo. This is what I call a placebo effect. They got worse, so network got worse, but these folks got better. How could that ever happen? And what we did is use some variant of the network mapping for within subject to actually take people under the blind who received sham surgery to determine where in the brain this effect could be that would make them, what network was expressed under the blind that hadn't been there before. And this was in JCI a few months ago from our group. But notice that one area that I kind of can't get over is Helen Mayberg's area 25 is very involved in this. And in fact, the Beck inventory was a covariate of this network. But when I controlled for that variance, partial regression, the UPDRS remained, So it was just that I think that they were feeling better on their back because they were moving better. But when I control the UPDRS, the effect on depression disappears. So I think that there was some causality there. The cerebellum is active as a covariant structure through the limbic system. This is the posteromedial vermis, which is part of the limbic system as it happens. I didn't know that, and I studied this work by Schmamann and others have really been not many people, and Peter Strick too, of course, that this type of thing was kind of amazing. And then the singular gyrus, you can see, and then this kind of cerebellar, and VA thalamus likewise. So limbic system, so just to show you, we go beyond these metrics of group mean, and it's all about individual performance. The techniques are completely non-parametric, computer heavy. I won't dwell on it, only to say that people who respond to sham surgery were improved, more network, and they also got better. They're responders as defined by criteria in the pain research field, where any improvement, period, including non-change, was considered a response to placebo because it's a progressive neurodegenerative disease. Over a 1 year period, it ought to have either been at par or gotten worse. So we only take, so this is derivation, and this is the testing set. There were 23 people, 16 were judged as responders. So one derives here, understands, and the network is hugely statistically stable because all the cases are in the same monotonic direction. And then the other group validates, and then also the non-responders don't exhibit this effect. Now, what if I made them better by just giving them plain old levodopa without a blind? They don't have that network. So you can see here that sham network response. So exuberant here, these are all testing data. I throw away the derivation. I never reuse it because it could be overfed. Notice here I made them equally good mechanically by levodopa, and that they're equal, and yet no network because it's a placebo thing. You have to be under the blind. It correlates with the individual differences in the outcomes under the blind too. It's pretty good because those data were not used to derive the pattern. This is all after the fact. So that's satisfying. Now, I just wanted to say this was a great study, and why I felt compelled to publish this is the blind was opened after 6 months. So we actually know what the fate was of people who had functioned under the blind. And you can see here that the majority of them lost their network expression. So whereas they had all been coming up between 0 and 6 months, those that had this dotted line is the upper limit of what Parkinson patients open label are going to do over 2 years in terms of the net. So we took a very broad range to call that kind of non-network. Anything above that is expression of network. Notice 2 of them actually came right. They had the worst, the hugest sham effect normalized. They go right down. But you also have some people who are told, I'm sorry to tell you, miss, but you got sham surgery. I don't know why you're better. I got better, doctor. But they're the ones that actually had this network expression that persisted. So they are true believers. No matter what we told them, they believe that they had a persistent placebo, persistent therapeutic effect. And it's exhibited by their network there. And then you have, I forgot what the slide was at this point, so I won't even dwell on it. Now, the only other thing, and then I'll close, is to tell you, so what, echoing Dr. Plum for the last time today, is what I really cared about here was, could I pick people a priori who were going to have that sham response? That's why we went through this. What inspired me was readings in the German literature, where it turns out a lot of effort currently in Germany is to develop protocols before enrolling participants in trials to see which ones are vulnerable. Notice this political sensitivity. The political, I was going to jeopardy may be the better term. I mean, what is to say that a person's personality makeup lends him or her to be prone to such a hysterical, the word hysterical is almost looming here, but something is, certain people are going to be disposed to this. But yet those are the killers of clinical trials. They are people randomized to control who are contributing disproportionately to the variance, right? Because they've never had the treatment. Yet they just had a sham, but they are exhibiting, they're like those true believer people you just saw. That's hardcore, So one thing we noticed is the baseline level that the network was expressed predicted a good degree, significantly, so not as much as the change. The change in outcome under the blind was very predicted by the network change. But the baseline was also informative. So those that really, when you look here, the people with the greatest sham effects are these in this pocket. So these are the people with low, the UPDRS went down under the blind in the face of sham surgery. Those people are, at the end, the individuals with very low initial values. So it's as if they deploy that network because they don't have it. It's an architectonically, phylogenetically old pattern that we've stopped using approximately 100 million years ago. Some long time ago, we've stopped relying on that particular limbic system. But it stays like many, like a cytoarchitecture and network of evolution. It remained to be used in a period of need. The rest of everyone has some network residual that's there, and you can't step it up because you're already using it. But a certain number of people are lacking it, and those are the ones who can invoke it and improve disproportionately under blinding. So a little experiment of Monte Carlo simulation. What we're going to do is pretend we're going to go back to our phase 2 study where all these data came from, that phase 2 study. By the way, where we removed all atypical patients a priori by that classification algorithm. So they already had baseline scans to use because we don't want any of those atypical guys in. And notice though, so we said, I'm going to take my sham responders. I'm just going to arbitrarily say anybody below the median in the sham responder group, that is a person that is likely or potentially likely to have that sham response in an exuberant way, and I will get rid of them. But since I haven't randomized yet, I'm going to be getting rid of every such person, even those who ultimately get randomized to the gene therapy. No one's been randomized yet. So anyone below that line in the baseline scan is now going to go away. And let me pretend as if I'm going to do my trial all over again where those individuals have disappeared, So first of all, let's see what happens. This is just a power calculation. If I were to go to phase 3 based on what I had seen with the current level of sham effect, it would require 188 people at minimum to get a 0.05 level of group difference, treatment group versus the sham group, based on this trial itself. And that's half of those people would get sham, 100 people would need to have sham surgery, at which point the thought police come, at which point you're done. That's not desirable, really. But we do need sham surgery in this context, but we perhaps don't need as much. If we remove that source of variance a priori, you end up doing your simulation. You needed only 88 people in total to be randomized, I think it was, or 92, can't remember, something like that. And so half of whom would have been randomized to sham surgery, so you're down to 46 from 100. So you've managed to kind of curb the need for sham surgery to some manageable degree, and yet your statistical power is equal to what had happened before. This is phase 2. So at least we don't have to kill any prospect of going forward by doing a trial without any help. Phase 2 is an underpowered study, right? But everyone wants to see some result. But we've made it with sham effects, we cannot. It just can't happen. But if we kind of find a way to look at these net effects of treatment, perhaps, by, I don't want to call it cherry picking, by intelligently excluding non-responders or people prone to sham effect, the possibility emerges where we could at least we would get a go signal on phase 2 and then plan a phase 3 accordingly. And so that's where this field is in terms of clinical neurology. I think we can improve our diagnostic skills. We can perhaps tell people in the clinic whether you will or will not phenoconvert to some morbid disease. Lastly, if we're treating people with a disorder of this sort, we may be able to do it in a much more efficient, better way than we are. So the technology is maturing in a way that will help us all as neurologists one day do our jobs. And I'll just close. Funding sources, friends, and thank you.
That was terrific, David. We really appreciate it. I am a little worried that your schedule is not going to accommodate a lot of questions, or you won't eat tonight. You have to pick.
One question. You can pick the questioner.
Sensible man. Please.
And I'm around tomorrow, so if there really are pressing questions, I I know that they could find me. We'll be seeing each other tomorrow too. Well, don't be so in one question. You mean no
Surely
question?
there are one. All right.
Yeah, sure.
So, back to the early part of your talk, I didn't understand the concept in the MSA people. If they have the same network, there are those that are primarily cerebellar and ataxic, and there are others that are primarily Parkinsonian. How do you put that all together?
So, yeah, it's that any individual case, so the network is what is common to all of them. You know, it's interesting because I look at these cases in a clinical PET reading too. I have never seen someone with just striatonigral who didn't have at least some cerebellar involvement. But those with ataxia have a predominance of cerebellar involvement. Those with Parkinsonism have the opposite, and many have both. So you get mixed MSA too. Those are the individuals, and that's what we believe we're treating. I'm treating the ataxia. But we're forgetting that working underneath is the whole neural system is pathologically affected some way. So they've got latent, even they may not have Parkinsonism yet, you just see the ataxia, but they are destined one day to have that too. So I think it's liberating. We're going to be lumping them for purposes of treatment, so that we're not helping them if we're saying you have the cerebellar type, you have the Parkinson type. It will help them if you did symptom-based treatment, but if the goal is to treat their underlying disease, we should try to strive for more coherent ways of treating the neural system. So what Sean Lee did is he had 40 cases of cerebellar type and a roughly equivalent number of Parkinsonian type in Korea. And he scanned them. And what we did is just looked at, it bothered us too. I mean, after all, half of these are just purely cerebellar. Why would they have the network? So we we used our own network, and it was abnormally expressed, elevated at high levels like 1.8 or 2 across the whole pond. And single cases were funneled through the algorithm correctly as MSA. Had they be they cerebellar or basal ganglia type. They were all assigned properly. So it ended up putting them in the right category, but it doesn't know enough to put them in a cerebellar or Parkinsonian through the image. So the question was, is there a signature of one or the other? So we derived a network that, just for fun, we said, okay, what is it that separates the cerebellar from, and you could manufacture, it's not very naturalistic or anything, but we found some construct that would allow us to, because you would just have it would look at the balance. In corticobasal, it's the side-to-side balance that gets assessed. Here it's the striatocerebellar balance, and you can assess that. And you would turn out to have people assigned based on a predominant blueness in their cerebellum, and the others would be blueness in their basal ganglia. So it's subtle differences side to side, between case differences, but the theme is the same disease. It's not two different diseases. So that's kind of useful. To me, as a treating doc, that's useful to know that these two people have the same thing, but one has a different problem than the other, so I'll focus on their ataxia. I'll give them ataxia drug B, or whatever. Good thing we don't have drugs for any of these.
David, thank you. So at the beginning, you mentioned, when the cartoon was up, you mentioned that one way to stratify groups was by genetic risk. So that would be a closer match, right? Two groups of Parkinson's disease, one with GBA variants, one without. Have you done work with that?
Well, not in a way. In fact, as I've been talking today, getting ideas about how for our renewal application. No, I think that would be fine. One thing I can tell you that I have done a little bit of, it's not rederiving. I think that what you want are carriers. What we did in Huntington disease and dystonia is to get the unaffected siblings or mutation positive. But these are illnesses that are recessive or only very limited penetrance, so that you may not get the pattern you're looking for. That said, taking PDRP and measuring it in LARC2 or two, or PINK1 or DJD, these different mutations. So we've done a few of each. And the GBA, different GBA mutations. But these are affecteds. You know, these are people who have Parkinson's, and they express PDRP all the same. The only difference was PDCP. The LRRK2 don't have cognitive stuff for whatever reason. So they have normal PDCP, you know, and DJD were riddled, and which was the recessive one in Europe. There's one of these early Parkin had terrible amounts of, consistent with their clinical status.
I pointed at Cyrus because he's
Is that right?
that the LRRK2 people with LRRK2 mutations are less likely to develop cognitive difficulties.
Yeah, that's true. And their scans, so we use different. They may not have a distinctive network, but the application of our known networks can be informative. You know, so you would, because you know, typically you never have I'll tell you one more curiosity is PDCP is always lower than PDRP as a necessary consequence of the Brock hypothesis. So we tested that in hundreds of patients, not just in our own data set, but in the world. We have access to these things. Let's say you don't have MSARP, PSPRP, you just had PDRP, PDCP, and you look at the difference between the two. Whenever it was a very, very good predictor, by and large, of assignment. So PDRP greater PDCP was always Parkinson's disease. PDCP greater was actually typically CBD or PSP because it had overlap, those zone networks overlap prefrontally. And so in LRRK2, it would be the exact opposite.
Right.
They have zero PDCP, so they're an extreme case of PD, if you will, a pure Brock stage 5, if you will.
Amazing.
Yeah. But no, I mean, Brock staging isn't all kind of silly either when it turns out that they're really, as he postulates, some temporal movement up there. At any moment in time, the scan is going to pick up more caudal than rostral because it began earlier or something. And that is played out diagnostically in these markers, you know, which is a novel. That's next year's story.
Thank you.
Thank you.